Good afternoon. Today we are going to cover the responsibilities of healthcare professionals towards vulnerable adults and children following from the updated policies of the 4 countries of the UK. I will start with children and follow through to adult safeguard. It is evident from reading the newspapers and watching TV that our society does not manage to protect our children from abuse and negligence. Moreover, we categorise children into deserving cases, such as baby P, and undeserving cases, such as the recent child abuse of adolescents in Telford, Rochdale, and name a city, without admitting that these are 2 sides of the same coin, that is, adults not taking responsibility for the care of children in our society. Safeguarding procedures apply to anyone who comes into contact with children and young people, even where they work predominantly with adults, and children are classified as anyone under 18 years old. The English government has recently revised the document called Working Together to Safeguard Children, a guide to interagency work to safeguard and promote the welfare of children. This follows much criticism about staff, especially social workers, being too concerned with form filling and ticking boxes and losing sight of the needs of children. The revised guidance aims to help professionals, that is, teachers, police, ambulance staff, healthcare staff, prison, probation, housing, youth offending, armed services, churches, sports clubs, voluntary groups and charities, etc., to understand what they need to do to protect children from neglect and maltreatment. This may arise from the family's circumstances and may not be their fault. Everyone who comes into contact with children has their part to play. Last year, over 600,000 children were referred to local authorities' children's services by concerned individuals. The underlying principles for child protection are the same in all 4 countries of the UK, but the processes differ slightly, so you will need to be familiar with your local guidance. For example, although Wales doesn't have a recent policy document, they formally adopted the United Nations Conventions on the Right of the Child in 2004 and made this the basis of all policy making for children and young people. At the stakeholder meeting groups around working together and subsequent meetings, it's become apparent that health staff need to step up to the plate around protecting children. Safeguarding and child protection means protecting children from maltreatment and harm, providing safe and effective care, and putting children and people first. And what we're being asked to do is be curious, think it through, think the unthinkable, and think child. We need to ask ourselves, why isn't this parent more concerned? Is something wrong here? Does something just not add up? Why isn't this child at school? What is this adult doing hanging around with this child? And is domestic abuse a problem with this family? Child neglect is one of the most pervasive forms of child abuse, which may be due to the family's circumstances and not their fault. But still the child needs your help. For example, the family may need more help to support a disabled child, or the child could be a young carer where the adult isn't receiving adequate services. If you see this slide, you'll see that there are plenty of things you'd recognise as a concern, such as faltering growth, anemia, incontinence, infections, dental problems. You'd be quite competent around that. But I want to elaborate on the last entry on this slide around mental health problems, as it is not widely understood how they relate to safeguarding. Research collated by the NSPCC shows that a child who is neglected in their first year can suffer from serious brain development issues. During a baby's first year, many of their neural pathways are forged and then strengthened by the kind of stimulus they receive from their environment. Poor attachment and low levels of interaction can alter how a child's brain develops emotional and verbal pathways. If a baby is malnourished, then the neural cells themselves can become weak or damaged, causing lowered brain function. The term global neglect has been used to describe children who experience several different kinds of deprivation. For example, language, touch, interaction with others. And studies have found that the brain of globally neglected children will be significantly smaller by the age of 3. The most severe of these killers will be when neglect begins early in a baby's life. Neglect can severely alter the way a child's brain functions, leading to an increased risk of depression in later life, as well as dissociative disorders and memory impairments. Changes to the brain caused by neglect have also been linked to the emergence of panic disorder, post-traumatic stress disorder, and attention deficit and hyperactivity disorder. Safeguarding is your responsibility. The Scottish Getting It Right for Every Child principles shown here on the slide are a good yardstick against which to measure your practice. All NHS organisations are subject to Section 11 of the Children Act and must have effective safeguarding systems in place, which are described as those where the child's needs are paramount and the needs and wishes of each child, whether baby or infant or child or teenager, should be put first so that every child receives the support they need before the problem escalates. All professionals who come into contact with children and families are alert to their needs and any risk of harm that individual abusers or potential abusers may pose to children. All professionals share appropriate information in a timely way and can discuss any concerns with colleagues. Now, if you've looked at the NICE clinical guideline 89, when to suspect child maltreatment, there's an interesting list of potential obstacles to recognising and responding to possible maltreatment. For example, you may have concern about missing a treatable disorder. You may fear losing a positive relationship with a family already under your care. You may feel discomfort and if you are disbelieving or thinking ill of or maybe wrongly suspecting or blaming a parent or carer. You may have divided duties to adult and child patients and be concerned about breaching confidentiality. You may have an understanding of the reasons why the maltreatment might have occurred and that there was no intention to harm the child, and that might prevent you from sharing information. You may fear losing control over the child protection process, and you may have doubts about its benefits. You might be under stress. You may fear for your personal safety, or you might have a legitimate fear of complaints being made against you. And although you've read a lot about whistleblowing recently, you still might not be sure whether this can apply to you in this circumstances. The NHS Constitution has been revised to include an expectation that staff will raise concerns, a pledge that concerns will be acted upon, and an undertaking to give clarity around the legal right to raise concerns. It's important that workers know with whom they can raise concerns, and all employers should have a clear whistleblowing policy in place. We would, however, always advise that you seek support from your union rep before making yourself very unpopular or putting your work at risk. And if you do have concerns and you aren't sure whether to raise them, you need to go and talk to your local named safeguarding. Children have said that they need adults to notice when things are troubling them, and then they need understanding and action to help put things right. That requires adults to be vigilant, to notice when things are troubling them, or to notice when their behaviour or physical appearance leads you to think they are being neglected. Children want to be heard and understood by adults and have that understanding acted upon. They need to develop an ongoing stable relationship of trust with those helping them. They need to be treated with respect and with the expectation that they are competent rather than not. They need to be kept informed about and involved in procedures, decisions, concerns and plans. Young people need support in their own right and advocacy to assist them in putting forward their own views. Some children are more vulnerable than others, and this might be only a temporary phase. Listen to the child or young person. There is no evidence that children lie or make things up. However, we do have ample evidence that paedophiles go to great lengths to persuade children to keep secrets. Remember to protect the child, not the adult, and be concerned where the child or the parent is disabled or has learning difficulties. The parent has mental health or alcohol or drug problems. Particularly be concerned whether a child is under the influence of an adult you don't trust. Remember, children don't have experience of whom to trust. And children in a secure setting are always vulnerable. All serious case reviews findings show that lack of sharing relevant information between professionals has hindered the opportunity for a child to be helped. Good record keeping and timely referral is fundamental to improving outcomes. The words on this slide are directly from the Working Together document, but can be equally shared across the 4 countries of the UK. Fears about sharing information cannot be allowed to stand in the way of protecting the safety and welfare of children, and no professional should assume that someone else will pass on crucial information. All staff working in healthcare settings, including those who predominantly treat adults, should receive training to ensure that they attain the competencies appropriate to their role and that they follow the relevant professional guidance. All providers of NHS-funded services, including NHS trusts, foundation trusts, public, voluntary sector, independent sector and social enterprises, should identify a named doctor and a named nurse or midwife, where that's relevant, for safeguarding. NHS Direct, ambulance trust, dependent providers should also have a named professional. The named professionals have a key role in promoting good professional practice within their organisations. Early years and childcare providers have a duty under Section 40 of the Childcare Act 2006 to have a designated practitioner to take lead responsibilities for safeguarding children within each early years setting. The Disclosure and Barring Service, DBS, helps employers make safer recruiting decisions and prevent unsuitable people from working with vulnerable groups, including children. It replaces the Criminal Records Bureau and the Independent Safeguarding Authority. They are responsible for processing requests for criminal record checks, deciding whether it is appropriate for a person to be placed on or removed from a barred list, and removing people from the DBS Children's Barred List and Adults Barred List for England, Wales and Northern Ireland. The Disclosure and Barring Service is, however, changing. From now on, the first check will cost around £44, and then employees will have an option to join the update service for £13 a year. That is free to volunteers. The benefit will be that one DBS check covers your entire career, as new employers could simply look you up. Where staff are registered with the update service, employers can check as often as they like, monthly if required. It will depend upon local arrangements whether the employer or the member pays for the updating service. Unite and other unions are seeking clarification from Home Office research. If you are a workplace representative, you should be pressing for employers to bear the cost, and for staff who do not have internet access at home to be able to apply for this on the computers at work. Just point out on that slide read it through carefully, because if you don't report someone who might be a potential abuser to the Vetting and Barring Service, you yourself could become a person who is barred from working with children. Under the Children Act 1989, local authorities are required to provide services for children in need for the purpose of safeguarding and promoting their welfare. So the Director of Public Health in the local authorities should ensure that the needs of vulnerable children are put onto the Joint Strategic Needs Assessment. Each local authority is required to establish a local safeguarding children's board for their areas, and there are particular organisations and individuals that should be represented on it, as named in the Children's Act 2004. This also sets out the objective of the LSCB, which is to coordinate what is done by the statutory agencies and make sure it is effective for safeguarding services. The LSCB will also set the local threshold of the need for services and will monitor and evaluate the training for all professionals. However, in England, the clinical commissioning groups are not coterminous with local authority areas necessarily, and members might find that they have to comply with different thresholds, policies and procedures depending on where their client lives and where they work. In Scotland, the Chief Executive of the Health Boards has the responsibility for local safeguarding. So obviously one way to deal with the potential for child protection is to plan abuse out of the system. Don't be alone with children, men or women. Ask permission to touch, even if you're doing a perfectly normal intervention such as giving an injection. Always ask. That way children learn that proper adults ask. And if you're doing a assessment for meetings or for clinics, consider the layout of the building. We know that abuses of children occur in secret places. And follow and enforce the IT policy at work. It's quite easy these days to almost stumble upon quite graphic child pornography without paying anything on your credit card. These things can be accessed through Google, or they can be inserted into your inbox just for a few seconds at a time, or 15 minutes to get you interested. If this happens, make sure that you report it at work. Go through your rep, because you have to be very careful that your own behaviour, however innocent, could be open to misinterpretation. Safeguarding adults is becoming much more onto the curriculum, and this is for anyone over 18 years. Now, there are no particular laws around safeguarding adults, but all criminal laws apply. However, there are around the countries now safeguarding adults boards, and also onto the agenda is coming more understanding of hate and mate crime. Disability hate crime is crime arising from hostility of the perpetrator towards the disability or perceived disability of the victim, or because of their perceived connection to disability. A mate crime, as defined by the Safety Net Project, is when vulnerable people are befriended by members of the community who go on to exploit and take advantage of them. Mate covers a wide number of people, including friends, family and supporters. Sometimes the exploitation may not be an illegal act, but it still has a negative effect upon the individual. The policies around adult safeguarding are no secrets, and that is guidance on developing and implementing multi-agency policies and procedures to protect vulnerable adults from abuse. It dates back to the year 2000, but it's still the basic policy that we use. Then the Mental Capacity Act in 2005 covered England and Wales, provides a framework to empower and protect people who may lack capacity to make some decisions for themselves. In Wales, the Social Services and Wellbeing Bill was introduced to the National Assembly for Wales for scrutiny in January. If this legislation is passed, it will provide the legal framework to transform social services in Wales, improving the well-being of people who need care. There are rules for keeping adults safe, but there is no law. There is a new definition of adult at risk and of harm. An adult at risk is an adult who is experiencing or is at risk of abuse or neglect, or who has needs for care and support, whether or not the authority is meeting any of those needs, and as a result of those needs is unable to protect himself or herself against the abuse or neglect or the risk of it. The bill also proposes to create a duty that everyone will have responsibility to protect adults at risk. There will be a duty to report adults at risk. This is quite complicated. You will need to read it if you work in Wales. This is to do with if a relevant partner of a local authority has reasonable cause to suspect that a person is an adult at risk and appears to be within the authority's area, it must inform the local authority of that fact. It goes on to say the same, but if the person at risk is in another local authority area, including if that person is living or proposing to move to another local authority area, including in England. The Welsh Bill also brings in adult protection and support orders. By this, an authorised officer may apply to a Justice of the Peace for an order whose purpose is to enable the authorised officer and any other person accompanying to speak in private with an adult who may be at risk, to enable the officer to ascertain whether that person is making decisions freely and whether this adult is at risk and decide what action should be taken. As I say, it varies from England in that there is a power of entry and there is this adult protection and support order proposed. And once the bill is passed into law, I strongly advise you to learn all these details if you are practising in Wales. In Scotland, we have adult support and protection, and this provides greater protection to adults at risk of harm through powers to investigate and take action to support and protect an adult in situations where concern exists. And it places a duty on specified organisations to cooperate in investigating suspected or actual harm, plus a duty on councils to make inquiries and investigations to find out whether or not further action is required to stop or prevent harm occurring. There are also a range of protection orders, including assessment orders, removal orders and banning orders, and there is the establishment of the local multi-agency adult protection committees across Scotland. This act was passed in 2007, and so if you are working with adults in Scotland, you should be well appraised of this. In England, we have the Care Bill, which is currently going through Parliament, and this set out the first ever statutory framework for adult safeguarding. And the government has agreed to give a new duty for relevant organisations to supply information on request to safeguarding adults boards. However, it has agreed not to establish a power of entry for local authorities in situations where abuse is suspected but entry allowed. So we'll have to see how that goes against the Welsh Bill, which takes a different point of view. In England, there's a new power for safeguarding adult boards and a general duty on local authorities to promote an individual's well-being. Other policies that support adult safeguarding are, of course, the European Convention on Human Rights. The key articles of that are Article 3, which is prohibition against inhumane, degrading treatment and torture. Article 5, the right to liberty, and Article 8, right to respect for private and family life, home and correspondence. You can understand that when we see panorama programmes about dreadful things happening to patients in learning disability situations, that right from the beginning the European Convention on Human Rights has not been adhered to, not to mention any other breaking of any laws. The NHS Constitution obviously sets out details around what is required from professionals and from clients. And in England, there's the National Learning Disability Programme Board, and the job of that board is to drive forward cross-government work to improve outcomes for people with learning disabilities within the new health, social care and welfare structures. This is following on from the final report from Transforming Care, which was a national response to Winterbourne View Hospital, which was the one on the Panorama programme. Secrets guidance, although it's old, it's quite a good description of the different sorts of abuse that adults can be subject to. There is physical abuse, such as hitting, slapping, pushing, kicking, misuse of medication, restraint or inappropriate sanctions, sexual abuse, including rape and sexual assault, or sexual acts to which the vulnerable adult has not consented, or could not consent, or was pressured into consenting. There's psychological abuse, including emotional abuse, threats of harm or abandonment, deprivation of contact, humiliation, blaming, controlling, intimidation, coercion, harassment, verbal abuse, isolation, or withdrawal from services or supportive networks. Financial or material abuse, including theft, fraud, exploitation, pressure in connection with wills, property or inheritance or financial transactions, or the misuse, misappropriation of property, possessions, or benefits. Then there's neglect and acts of omission, including ignoring medical or physical care needs, failure to provide access to appropriate health, social care, or educational services, the withholding of the necessities of life, such as medication, adequate nutrition, heating. And then there's discriminatory abuse, including racist, sexist, that based on a person's disability, and other forms of harassment, slurs, or similar treatment. I think you'll agree that's fairly comprehensive, and if we just stuck to that list of things, we wouldn't ever have an abusive adult situation. The Mental Capacity Act makes clear who can take decisions, in which situations, and how they could go about this. Anyone who works or cares for an adult who lacks capacity must comply with the Act when making decisions or acting for that person. This applies whether decisions are life-changing events or more everyday matters, and is relevant to adults of any age, regardless of whether they lost capacity. The underlying philosophy of the Mental Capacity Act is to ensure that those who lack capacity are empowered to make as many decisions for themselves as possible, and that any decision made or action taken on their behalf is in their best interests. It relates to empowerment. Every adult has the right to make his or her decisions and must be assumed to have capacity unless proved otherwise. Just because an individual makes what might be seen as an unwise decision, they should not be treated as lacking capacity to make that decision. Protection is support and representation for those in greatest need, and a person must be given all practicable help before anyone treats them as not being able to make their own decisions. Prevention, it's better to take action before harm occurs. Proportionality, that is, the proportionate and least intrusive response appropriate to the risk prevented. Anything done or any decision made on behalf or for a person who lacks capacity should be the least restrictive of their basic rights and freedoms. Partnership, which implies local solutions through services playing their part in detecting and reporting neglect and abuse, and accountability and transparency in delivering safeguarding. I've just put a slide here about regulation because all these things are fine, but who's going to keep to them? Well, most criminal prosecutions are the responsibility of the police through the Criminal Prosecution Service. The Health and Safety Executive Crown Prosecution Service. The Health and Safety Executive can prosecute under health and safety at work legislation, and the Care Quality Commission can do so under the Health and Social Care Act 2008. Also, local authority trading standards officers have some responsibilities, and of course professional registrants' code of professional practice should cover the way that we behave. Professionals who complain or issue against them regarding poor safeguarding practice are in serious trouble with their professional bodies. So if you are in trouble, please contact your local rep. Do not write any statement without advice from your rep or from a professional officer. Do contact the professional officers in Unite at the earliest opportunity, and do find evidence of your recent CPD. Remember, prevention in all cases would be cure, so do seek advice and support if ever you've got some concerns around a safeguarding issue. Thank you. At our 2012 conference, we launched our CPD, and we're currently testing on the Community Practitioner Journal website. CPHDA members from Unite will be able to undertake a CPD module as part of today's training session, which they will be able to access at www.communitypractitioner.com. This will include some multi-choice questions and an area for reflection. Once completed, members will be able to store or download their certificate, and we will be launching this resource to the wider health sector in the coming months. Meanwhile, the ways to keep in touch and keep up to date is via our website, www.unitetheunion.org/health. Make sure your membership details are up to date so that you get all our emails, bulletins, texts and letters. You can contact your Unite membership at 0330 123 3003 in UK, or in Ireland 189 09 46 241, or go to the website and click on the member login button at the top right hand corner of the website homepage to register and or update your account. If you receive one of our professional journals, that is Community Practitioner, Mental Health Nursing, and any of the other journals from the professional organisations, do make sure you read it, because we put so much effort into making sure that it's up to date with the information you need. And keep an eye on us via Facebook, that's www.facebook.com/UniteInHealth, or Twitter, www.twitter.com/UniteInHealth. And get involved in our Save the NHS campaign if you go onto the website www.unitetheunion.org/SaveOurNHS. Thank you.